Good afternoon. My name is Dr. Clement Ngcuka. I'm presenting to you a relatively new topic. This is now drug-resistant TB. We've always been talking about drug-sensitive TB. Today it's going to be drug-resistant TB, and we would like to know which locus are we looking at when we are talking about drug-resistant TB. We're looking for instance, at the genome of Mycobacterium tuberculosis, and we're looking at a particular locus, the RPOB gene. The RPOB gene is the one that is susceptible to rifampicin. Now, if suddenly it doesn't become susceptible, it doesn't become sensitive to rifampicin, then we say this is rifampicin-resistant TB. And this is, we are saying, we have in mind that there are 4 antituberculous drugs. There are 4 of them: rifampicin, INH, pyrazinamide, and ethambutol. If one of these is being resisted, then we say we have a monoresistance. If 2 or more are being resisted, we say we have polyresistance. But with polyresistance, we must make sure that INH and rifampicin, they are not there, they're not being resisted, because those are the 2 potent antituberculous drugs. And if they are being resisted, we're talking about a new type of resistance. We're talking about multi-drug resistant TB. In other words, when rifampicin and INH are being resisted, we say we have multi-drug resistant TB. People call it MDR-TB. This is important for us to understand, because these are the 2 potent antituberculous drugs. We are looking at a locus in the Mycobacterium tuberculosis, the actual bacterium. We're looking at a locus there known as RPOB gene. That locus is the one that determines the susceptibility or the sensitivity of rifampicin. But what about INH? INH has got a locus known as INHA. This locus, if it is being resisted, then we're talking of low dose resistance. Because we call it low dose because normally when we treat with using INH, we always give 300 milligrams of INH daily. But if it's being resisted, we are going to raise this dosage of 300 milligrams to 600 milligrams, and you'll find that the resistance will not be there. It was just a low dose resistance. When you up the dosage, the resistance goes away. So that's low dose. But will INH, will it ever be resisted totally, completely? Yes, the answer is yes. Because when the locus that determines the, shall I say, the high dose, it's called CAT-G. There you have catalase peroxidase. Catalase peroxidase is an enzyme that's supposed to convert a prodrug that is INH. INH is a prodrug. it has got to be converted to an active form. So now, if this catalase peroxidase is not able to convert it, then we're having now iron 8 that's being resisted, and that's bad news. We call it CAT-G, this catalase peroxidase. That locus is called CAT-G. So if you have got these two, then you will know that iron H is being resisted. In fact, if it's iron HA, then you know there's low dose resistance. High dose resistance is when you have CAT-G, that is the catalase peroxidase. And this is bad news for the patient, because if these two, that is rifampicin and iron H, are being resisted, then we have multi-drug resistant TB. And then we have to change suddenly now. We can't use the RIFA-4 that we've been sort of proud of and saying that RIFA-4 handles Mycobacterium tuberculosis well. We have to change now. We have to go to drug-resistant TB treatment. Drug-resistant TB treatment, what are we talking about here? We're talking about drugs. They're completely new drugs, and they are called BPAL-L. BPAL, let me just explain them one by one. B is for Bedaquiline, and then the P is for Pretomanide, and then the L is for linozolid, and then dash L. L is for levofloxacin. Levofloxacin is a fluoroquinolone, and our fluoroquinolone of choice is moxifloxacin. But we're not using this because, you know, many drugs have Bedaquiline, levofloxacin, Pretomanide. They prolong a QT interval. That's unfortunate. And when we say a QT interval, this is something that we always check when we do an ECG. And we don't like this at all. We don't want prolongation of a QT interval. So that is why we change the most potent fluoroquinolone, which is moxifloxacin. We change it. Let's rather use levofloxacin, because levofloxacin is used in children. And so the prolongation of a QT interval is not that much. So let's use that one. I mean, we're thinking Bedaquiline was going to prolong the QT interval. Now let's use something that is less potent, that is, well, in terms of prolongation of a QT interval. Right, because we don't want it at all, because it causes something very, very bad. So it causes these you know, arrhythmias, polymorphic, you know, arrhythmias, and polymorphic ventricular arrhythmias. And, you know, patients normally die from this. We don't want this. We always want to make sure that before we use these, let's weed out and get rid of any drug that could be prolonging a QT interval. Like, for instance, you know, if the patient was using Bedaquiline for sleeping or something like that, let's weed it out because it prolongs the QT interval. So basically, this is what we use. We use Bedaquiline, Pretomanide, linozolid, and dash levofloxacin. But when you're using linozolid, one has got to watch out. So there's something that you have to, there's no way that you can overlook it. And you have to check your HB, your hemoglobin. Your HB has got to be greater than 8 grams per DL. Has got to. Otherwise, if it is less than, then BPAL is not the right choice, because that linozolate is going to push it down the more, the HB. So we don't want that. We want to make sure that when we are going to start this BPAL, we want to make sure that the HB is greater than 8 grams per DL all the time. This is all the time. Or otherwise, the patient has got to be admitted, and so that there should be a blood transfusion, just to make sure that, you must remember, it causes an anemia, and we don't want any form of anemia. We don't want to be dealing with anemia when you are using linozolate, right? Because it's going to make it worse. So basically, that's what we need to do. But how do you know that rifampicin is being resisted? We have to do a very important test. They call it a nucleic acid amplification test. The example that we use as a nucleic acid amplification test is what is known as gene expect. And gene expect is targeting that RPOB gene, is targeting that. It's checking whether rifampicin is this position susceptible to rifampicin or not. In other words, is RPOB gene, the locus on the Mycobacterium tuberculosis genome, is it sensitive to rifampicin or not? If it is sensitive to rifampicin, and it means that rifampicin is working very, very well. It means it's working very, very well. It is going to stop the TB, right? But if it is not sensitive, we've been dealing with TB that is, we call it DSTB, drug susceptible TB. That's the TB that we've been dealing with our RIFA4, right? But now we can't use this. If the RPOB gene is resistant to rifampicin, then we're dealing with the RR, rifampicin resistant TB. Rifampicin resistant TB. With rifampicin resistant TB, there are all types of drug resistant TBs. They are classified under this, because even pre-XDR falls under this, because there will be rifampicin that is being resisted, but accompanied by what? Accompanied by a fluoroquinolone. A fluoroquinolone, which fluoroquinolone are we thinking about? We're thinking about levofloxacin, because we can't think of moxifloxacin because of what I explained, the prolongation of a QT interval. We have to think of levofloxacin. So if levofloxacin is being resisted, then we're talking of something called pre-XDR. It's not just an ordinary RR or rifampicin resistance. We call this pre-XDR. Pre-XDR, it means we're going now, we're knocking at the door of XDR. What is XDR? Still, it's like pre-XDR in the sense that it will be rifampicin resistant, and then it will be fluoroquinolone resistant, which is levofloxacin in this case, and then this time there's an addition to make it XDR. Bedaquiline is going to be resisted, or linozolate is going to be resisted. So if now there are three drugs which are being resisted, one is rifampicin, number 2 levofloxacin, number 3 bedaquiline or linozolate, right? We call them the group A drugs, those linozolate and bedaquiline. If any of it defines now an XDR. And this is very, very difficult to treat. Very difficult to treat. And that is why we want to make sure that there is no... In fact, when there's pre-XDR In other words, you have got a fluoroquinolone that is being resisted. When you think of fluoroquinolones, which other moxifloxacin is the fluoroquinolone, levofloxacin is the fluoroquinolone, ofloxacin is those are fluoroquinolones. If any of those is being resisted, then we know that we're dealing with pre-XDR. And now you're going to change your BPAL-L. You're going to change it to BPAL only. In other words, you're going to use Bedaquiline, you're going to use Bretomanid, and you're going to use linezolid without levofloxacin because it is being resisted. Right, and that's important. That is very, very important to know that if I have a pre-XDR diagnosis, then I know that I'm going to use BPAL. If I have all the others, I don't have a problem, I'm going to use BPAL-L. If you walk into a ward and you are told that the patient has drug resistance, then what you expect, what if the HB is greater than 8 grams per DL, what you expect is to see BPAL-L. That's what you expect. But then you have to check. You know, there's a test that we normally do each time there's drug resistance. They call it MDR-TB reflex test. MDR-TB reflex will do all the tests from GeneXpect. And you know, look at that RPOP gene. And you'll do all the tests. Even smear positive, smear negative. Now this, in other words, microscopy will be done. Culture will be done, you know, to make sure that you get all the tests, even the phenotypic DST. DST is what? Is drug susceptibility test. All those will be done to make sure that when we are giving BPAL-L, we should know what is going on. Because what we're going to do now, we're going to check a genotypic result and check, is my rifampicin still being resisted? Yes, it will be resisted, because that you can't use BPAL-L if it's not resisted. Then you have got to check, how are my two drugs, how are my mutations there of the two drugs? Like I'm talking about the INH. Remember INH, we said there are 2 mutations there which determine resistance. And we said it's INH-A and CAT-G. If those are there, I'm going to continue with my BPAL-L. Right? I'm going to continue with my BPAL-L. I will only discontinue BPAL-L if the fluoroquinolone is being resisted. In other words, when levofloxacin is being resisted, then I'm going to use my BPAL. All the others, even XDR cartridge, when it is unsuccessful, I'm still going to continue. I'm still going to continue with my BPAL-L. I want to say thank you very much for listening to me. I'm going to continue with this. I'm going to continue with this to let you know what happens when we have extrapulmonary TB. When you have extrapulmonary TB, when we say extrapulmonary TB, we're thinking of what? We're thinking of TB meningitis. We're thinking of, that is a CNS, disease. When we have a CNS disease like TB meningitis, we have osteoarticular TB, the bone TB and all that. When we have an abdominal TB, an abdominal TB, peritonitis and then distended abdomen, and then this TB, this abdominal TB. When you have those, then we're going to use a new a new method of attack trying to treat this drug-resistant TB. We're going to use what is known as individualized long regimen, because what we've been using, that BPAL-L, is what is known as a short regimen. Thank you very much, guys. I will continue with this and make sure that you understand what's going on. I think that will be my next video. Thank you very much for now. Everything of the best. Enjoy it. Go over it slowly. Go over it slowly. How do you start? RPOB gene. RPOB gene being resistant. You start there using your gene expert. You can't forget this. Okay, thank you very much. Bye-bye, guys.